Good afternoon, everybody. I want to thank Dr. Donagionakis and Dr. Brilakis to include me in this wonderful panel. And my topic is when and how to use lateralization from the humerus. I started my RSA practice in 2007 in the United States. And the beginning I was using the Grammont style prosthesis, the Delta 3. And actually, with this type of implant, I had very good clinical results. And then I moved to more lateralized prosthesis, RSA prosthesis, such as Tournier prosthesis, Arrow, which is very too much lateralized, and recently in FX shoulder solutions. But no device is perfect. We know that you may see instability. Sometimes, if you over-lateralize, you see overstuffing. Notching is a problem, even if you lateralize or not, or medialize the center of the rotation. And if you over-lateralize, you may see acromial or humeral stress fractures. So there have been changes to the classic Grammont design in order to improve range of motion and outcomes. And these adjustments include the glenoid base plate placement, as Dr. Vezeridis mentioned. He already mentioned. And I'm going to talk about the humeral side design changes. These are the designs, the more common design options, where we have medial glenoid, medial humerus, lateral glenoid, medial humerus, medial glenoid, lateral humerus, and lateral glenoid and lateral humerus. The Delta prosthesis has a neck shaft angle 155 of valgus, providing superior stability in calf tear arthropathy. And more recent studies offer an NSA closer to the normal anatomy, with options between 135 and 145. The Grammont initial stem was inlay type humeral tray. However, this type of inlay involves removing more metaphyseal bone and preparation and may risk graded tuberosity fracture. And then the onlay designs preserve the proximal bone and the graded tuberosity, and thus minimizing the damage of the remaining calf. Rootman, in 2015, defined the humeral offset. And according to these authors, humeral offset is the distance between the center of the intermedullary axis of the stem and the center of the humerus liner. And they suggested that they termed that if a humeral component has an offset less than 15 millimeters, considered medialized, and if it has an offset more than 15 millimeters, is considered lateralized. Of course, humeral lateralization is influenced by the anatomy, humeral neck angle, the humeral head osteotomy, and the different inserts of the humerus. From a biomechanic study, has been shown that changing the NSA from 155 to 135 only leads to a minimal lateralization of 3.2 millimeters. In 2019, Werthel and his colleagues published this very good paper with a descriptive analysis of 22 different implants in current practice. And because of the different humeral liners that exist, the polyethylene liners that exist, they were more detailed, and they were defined the humeral lateral offset, the distant AC. And what is AC? It is the sum of the humeral set offset between the center of the stem and the center of the humeral cut, and the humeral inset offset, which is the deepest point. They call that pivot point, which is the deepest point of the polyethylene liner. So, for these authors, humeral lateral offset is the distance AC. And these authors said that medialized humerus is when there is this distance is less than 5 millimeters, minimally lateralized when it's between 5 to 7 millimeters, and lateralized when this distance is the humeral offset is more than 10 millimeters. They compared 22 different prostheses regarding and used as a reference the Grammont delta prosthesis, which has a global lateralization 13.1 millimeters. And if you see this nice illustration, you see at the top the delta prosthesis, and the more lateralized prostheses are at the bottom of this illustration. So what are the theoretical advantages of the humeral lateralizations? It may restore a more anatomical position of the humerus, and therefore we preserve the lesser graded tuberosities, and we may lengthen the remaining rotator cuff. And a more lateral position of the graded tuberosity increases the abductor lever and the wrapping angle of the deltoid, which increase the compressive forces. These are the disadvantages of the humeral lateralizations: a high incidence of scapular fractures associated with, especially with onlay systems. There is a biomechanical study in shoulder and elbow 2016 that showed that up to 5 millimeter, there is no any risk for acromial stress fracture. On the other hand, we should be very careful because distalization and arm over lengthening has been attributed as a possible cause to severe nerve injuries. Let's see the outcomes from some recent studies that two of them are meta-analysis. In this study, 2021, it's a meta-analysis that compared glenoid lateralization versus humerus lateralizations. They studied on 385 cases, 95 cases with lateralized humerus and 257 cases with lateralized glenoid system. The outcomes were similar for both groups. However, they concluded that when the subscapularis was able to be repaired, the lateralized humerus prosthesis seemed to obtain better scores and range of motion. Another recent study that it's a systematic review. It concludes 9 studies, and it has 562 patients that compare lateralized humerus to more medial design humerus. So they compare lateralized humerus more and less lateralized humerus. And from this meta-analysis, there was a reduced risk of scapular notching in lateralized humerus. And interestingly, the external rotation in the lateralized group was statistically significant. This is a more recent study, 2023, that they compared, they did a comparison between glenoid and humeral lateralizations. And they analyzed 122 patients. In group 1, 60 patients, they used glenoid lateralization. Group 2, 62 patients, humeral lateralizations. The results were about the same, no significant difference in order about the scapular notching and the clinical outcomes. However, the humeral lateralization RSA showed a larger glenoid tuberosity distance, and less distalization shoulder angle, the DSA. In this study, the complications were about no significant difference about the complications, but revision surgery was performed from 2 humeral loosening in the group 2, the humeral lateralization. So how much to lateralize? We have to be very careful because there is a risk of excessive global lateralization. There is a potential of overstuffing of the joint, especially in thin patients, where you may see some joint contractures, and they may lead to stiffness and reduced range of motion. When you do too much distalization and you are unable to repair the subscapularis, you may have neuropraxia and you may see acromial stress fractures. According to this study, Werthel stated that the goal should be anatomic insertion and tensioning of the remaining rotator cuff. To achieve that goal, they recommend graded tuberosity lateralization of 0 millimeters. And when measured the humeral lateral offset, they stated that the surgeon should be cautious with lateralization beyond 5 to 10 millimeters, depending on the amount of the loss of the medial bone stock. And for the distalization, the surgeon should be very cautious with distalization beyond 35 to 40 millimeters. Recently, I used this 3D planting software, and I'm trying to balance the lateralization of the glenoid regarding the humerus lateralization. To conclude, humeral lateralization could preserve the normal shoulder anatomy due to a larger gradient tuberosity distance and provide less deltoid tension due to the less DSA. However, the ideal amount of global glenoid-sided and humeral-sided lateralization and each patient-specific modification remain unknown. Thank you.